Hello, everyone. Welcome to our webinar today in honor of World AIDS Day. My name is Dr. Rachel Vreeman. I'm the chair of the Department of Global Health at Mount Sinai and the director of the Arnhold Institute for Global Health. I am also a pediatrician who specializes in the long-term care of children and adolescents growing up with HIV. And it's really my honor and privilege to be able to mark and honor World AIDS Day on this December 1st with everyone who's joining us. I'm incredibly excited too about the guests that we have with us today. I will introduce them in just a moment, but I did want to take a moment to offer a little bit of framing for our session today related to World AIDS Day. First, we really believe in and wholeheartedly embrace what you see on the screen there, that we stand today in solidarity with all people who are living with and who are affected by HIV. It's our privilege to mark this day and to stand in that solidarity together. Could you go to the next slide, please? We also wanted to take a moment to dedicate today's webinar session to two colleagues who are very close to many of us and who both passed away within the last several weeks. Dr. Paula Breitstein was an epidemiologist, a leader in research and advocacy related to HIV, and in particular an advocate for the needs of vulnerable youth and street-connected youth and young people living with HIV. She lived and worked for many years in the Kenya Partnership in which I've worked and which our guests today also collaborate. And we really want to honor her memory as we have this discussion today. In addition, we also were sad to lose Dr. Joe Massey in the last few weeks as well. Dr. Massey was also a faculty member in our Department of Global Health here at Mount Sinai. He was the director of the Global Health Institute at the Elmhurst Hospital and a long time, not only infectious disease specialist, but leader in the development of HIV care programs, first in the early days of HIV treatment in New York, and then in global HIV care development, particularly in Ethiopia and Russia. So really, we want to also honor their memories today as we hold up the memories of those whose lives have been ended by HIV, as well as those who are living with and continue to be affected by HIV. Next slide. And one other memory, actually, if you could go back just one, Amanda. For those of you who've spent World AIDS Day with me before, you know that I always mention Faith. Faith is the little girl pictured here with her mother. Faith was actually the very first patient that I lost to HIV. She came into our referral hospital in Kenya when she was 4 years old. Unfortunately, her HIV had progressed quite far and she passed away just a few days after she came to our wards and after this photo was taken. I had permission from her mother to share this photo, and her mother actually treasured this picture because it was the only picture that she had of her daughter. And I remember Faith and bring up her story every year on World AIDS Day on December 1st, not only because her loss was the first of many losses that I personally experienced as a pediatrician working with children with HIV, but especially because December 1st was her birthday. Faith should be 22 years old today. And as we think about World AIDS Day, I want us to think of the birthdays that should be celebrated as we consider those whose lives have been ended far too early from HIV. And at the same time, we also want to give thanks and celebrate the birthdays that do get to be celebrated, that were celebrated this last year, that will be celebrated in this next year, because of the treatments that are available and the access to treatments that are available. So we're going to talk more about what this transformation looks like, but I did want to mark and honor Faith on World AIDS Day as well. And then just one more slide before we start our discussion together. So As we consider World AIDS Day together, as the Arnhold Institute for Global Health and the Department of Global Health at Mount Sinai, and the partnership in which it happens that all three of us here on this webinar engage in, the AMPATH Kenya webinar, we really want to continue to draw attention to the ways in which we must continue to unite to end the inequalities and the inequity that's holding back the end of AIDS. HIV is not over. This is not a pandemic that is over. I know we don't hear as much about it. Maybe some of us who are not doing this work every day have a tendency to think that we've solved this, that it's not something to be worrying about. But HIV is still an enormous problem for much of the world's population and for the world's children as well. Last year, the estimate is that 38 million people globally were still living with HIV. That includes about 2 million children who are below the age of 14. And when we look at adolescents, those between 10 and 19 years, about 2 million adolescents are living with HIV globally. And more than half of all of those living with HIV are women and girls. It's really become a pandemic of those who are most vulnerable. And in particular, we see so many risks and so many of the new infections among young women and among girls. And while we do, of course, celebrate the many advances that we've had in 40 years of struggling and knowing about this virus, we also continue to lose people to HIV. An estimated 650,000 people died from HIV-related illnesses last year, and AIDS remains in the top 3 causes of death for adolescents in African countries. So this is still a pandemic that continues to steal lives away, and a pandemic that we need to continue to shine light on and focus attention on, as our speakers today will talk about. And I think when we consider the role of inequity in this, it's particularly striking to think that, this is a pandemic that we can prevent. We know how to prevent HIV from ever passing from one person to another, including from mothers to babies. And the available treatments for HIV make HIV into something that you can live with for a normal lifespan. So our very real goal today for every single person living with HIV is that their HIV medicines, their antiretroviral medicines, would suppress the virus so it's undetectable in their blood and so that they cannot infect another person. We know from science now that undetectable equals untransmissible. You can't pass the virus on. So it's really our hope to make access to effective medicines available to each and every person, children, adolescents, adults of all ages, so that HIV can be just one part of the story for people who are living with this infection, that it's not the end of their story, it's not the end of who they are or who they'll be. Let me introduce our speakers joining us today. Let me just grab my introduction here. I'm going to ask them some questions. I'm excited to talk with them and have them share their stories with each of us. And we'll leave some time at the end for those participating today to ask questions. So if you want to type questions into the chat box, please feel free, and we will try to address some of those at the end. So joining us today, first we have Professor Winston Nyandiko. Professor Nyandiko is a professor of child health and pediatrics at the Moi University School of Health Sciences in Eldoret, Kenya. He has been a part of Moi University in one way or another since 1996. He became a lecturer in 2002, moved through the ranks to senior lecturer, associate professor, and all the way to full professor. He's served in multiple roles at the medical school that include being the head of department for the Department of Child Health and Pediatrics. He's been the chairman of the clinical division in the School of Medicine, the chairman of the Credit Transfer Committee. He's also the chairman of the School of Medicine's Research Committee and the Health Sciences Quality Assurance Committee. In addition, as a pediatrician, he has served in charge of the newborn unit and for a long time was the lead for pediatric care within the large HIV treatment program grown out of the AMPATH partnership in Kenya. Professor Nyandiko is also the executive director for research in the academic model providing access to healthcare, or AMPATH partnership. I am also have to note that Professor Nyandiko is a national leader in HIV care, serving on the Kenya National AIDS Control Panel, as well as a global leader with research work and contributions to clinical guidelines for HIV care in children and adolescents that have been part of global guidelines, global toolkits, and at an international level in every point. I'm going to stop talking about his many accomplishments because we want to hear from him directly as well, but I should note that Professor Nyandiko and I have collaborated for a long time, and probably at least 80% of what I know about how to treat children with HIV, I learned from Professor Nyandiko beginning back in 2004 when sometimes it was just the two of us in one single room at the Moi Teaching and Referral Hospital, where we were seeing kids with HIV, now growing to the program that he's led for so many years that spans over 400 clinical sites providing HIV care. We also are delighted to have with us Dr. Lonnie Embleton. Dr. Embleton is an assistant professor in the Department of Global Health and Health System Design here at the Icahn School of Medicine at Mount Sinai. She is also an adolescent health advisor for the Arnhold Institute for Global Health. She is passionate about generating high-quality evidence to improve health, economics, and social outcomes for underserved adolescents and to achieve health equity. For the last 10 years, Dr. Embleton has also conducted research in Kenya, particularly with street-connected youth and with orphaned and vulnerable children, emphasizing how we can advance their sexual and reproductive health, their human rights, their HIV-related care, gender equity, and to improve the social and structural determinants of health. She has had many achievements as well in her career, including being nominated for the Canadian Women in Global Health List, and she received the prestigious Vanier Canada Graduate Scholarship and Doctoral Research Award from the International Development Research Centre. Dr. Embleton holds a PhD in medical science from the University of Toronto, as well as a master's degree in public health from the Dalla Lana School of Public Health at the University of Toronto. We are delighted to have her as both one of our collaborators and part of our group as well. And again, thank you to both of you so much for joining us today from Kenya and from New York. Professor Nyandiko, I'm going to start with you. Again, thanks for joining us and for this time. For those joining the webinar who may not be as familiar with your work as of course I am, could you summarize for us some of your work with children and youth living with HIV? And I'd especially love, as we mark this World AIDS Day in 2022, for you to tell us a little bit about how the needs of children and the care for children has evolved since the beginning of your career in addressing and taking care of children with HIV.
Thank you, Rachel. Very warm introduction. It made me flush a bit, but thank you to the Mount Sinai team for inviting me to talk about the children, adolescents, and youth who are HIV infected, and we've been taking care of them for a long time, as Rachel has mentioned. So I'm a professor of child health and pediatrics and a pediatrician who joined Moi, as Rachel mentioned, in 1996. Then as a black-haired young man, very enthusiastic, and that's the time I think HIV was starting to do damage to the communities, especially after 2000, when I had just graduated as a pediatrician from University of Nairobi. I joined Moi, and I've since grown through the ranks. Currently, I serve as the Executive Director for Research within the AMPATH program, a partnership which was born in 2002, primarily to tackle the HIV pandemic. And I think the initial wording for AMPATH was academic model for the prevention and treatment of HIV. which has since, of course, metamorphosed to looking at other conditions, including other chronic diseases, hypertension, cancers, and diabetes, and so on. So in terms of just a brief history about what we've done and what has changed over time, I got involved in 2002, as I mentioned. At the time, there was no public institution which was offering any treatment to adults and children. So we could just watch people come in with the latest stage or severe HIV, just to die. We even had a cubicle in the adult ward we used to call Siberia, where once a patient has been taken there, you are aware that that patient might not survive the week and so on. We, in 2003, were lucky enough to get some funding from Purpleville Foundation that gave us the ability to start adults and children on treatment. Remember, these are drugs which have never been used in the public sector. A few people in the private sector are using them. And they were toxic regimen, as you remember, some of them, for those of us who are connected to the ART changes, drugs like stavudine, SRT in high dosages, and so on. And so we were then able to start a few children and adults on treatment. And we used to make a decision on who was going to live, because there were very many people who needed the ARVs, and there were few. So you used to categorize them according to their severity and start on the most, treatment of the most sick of them all. In 2003, I was lucky to go to FXB in Newcastle, USA, and get some training, on-site training on HIV care in pediatrics. And that really started my journey. And of course, we all know that in 2004, PEPFAR came along, and we were able now to start giving ARVs to many more people, but still prioritizing those who are very sick. Since that time, we've been involved in a lot of care for the complicated cases. We've been doing mentorship to bring people who can do the same treatment, and a program expansion across Western Kenya and actually the whole of the country. So we, of course, initially were using paper encounter forms. If you were with us in 2003, 2004, we were just scribbling the information on paper, but we had to standardize the information we were creating. And if you fast track to today, all that data forms that we used to fill that were standardized, and they were standardized working with John Saido, Kara Wools for the adults, Joe Mamlin, Professor Kimayo, and myself for pediatrics, really to say what information must we collect uniformly for us as we take care of the patients. These are now programmed electronically in POCs, and so clinicians just enter that information directly. At the beginning, we had only 2 clinical officers and 2 nurses in the clinic that I was leading in the MTRH outpatient, very small space. And we used to have it on a Tuesday afternoon. And you can imagine the congestion. The adults used to have a room called 42 that was also very congested. But we have mentored teams and expanded at that time to Mosorio, Tarba, and Ban Forest, which are within Western Kenya, but now cover the whole of Western Kenya, the 8 counties, including Uasin Gishu, Nandi, all the way to Bungoma, Trans Nzoia, and so on. And during the beginning, of course, there was a lot of need for technical advice at the Kenyan Ministry of Health level. And we are co-opted, myself and Prof. Kimayo, Prof. Sika, Prof. Were, to start drafting guidelines and training materials, which we did. And we were actually quite involved in setting trainings at the national level in Nairobi. We used to be called for people to come from all over the country to be trained on HIV care. And up to date, we're still in those MOH, Ministry of Health working groups, and contributing to changes in guidelines as information comes up. In 2004, as Rachel mentioned, I think we met early 2004, 2005, we decided that we needed to collect and review the data that we are collecting more systematically. And we formed one research working group within AMPATH look at a way of looking at the retrospective data we are collecting and seeing whether it can help us improve our care. And so we drafted a proposal, and IREC gave us permission to use the data that we had to retrospectively review a lot of the work we are doing. And the journey started with that one research working group. And that time I was the boss of the research program, then called assistant program manager for research. But fast track to today, we have over 11 research working groups that are doing very well, including the adult research working group, pediatrics, and so on. And this journey, we've worked with many partners and funders to develop this robust research and care infrastructure. We have a database that is a research database cleaned up. We have a reference laboratory, we have data management and biostatistics scores. You have a clinical trials unit which is able to do randomized clinical trials, including vaccine trials. And we have increased our communication capacity. And of course, more recently, we are improving on other kinds of research, including qualitative research core. So my pride in this journey is that we've seen many cohorts of children grow through childhood and adolescence and into adulthood. We have currently some of the people we saw when they were 7, 8, 9 years, working in our program as adults and married and getting children, and their peers, and they are very useful in helping us navigate the journey of improving care amongst other adolescents and youth. Few of my early cohort of patients are currently in university, and tens of them successfully employed, including 2 medical doctors for our information. So I'm very proud, and there's a lot I can say about that journey, but the biggest achievement is really saving lives, having improved the landscape of care that you can use middle level and lower level medical staff by mentorship and trainings to take care of millions of those who require treatment. In our program, we have over 150,000 adults and children who are on treatment. And I still run a clinic in Module 4 within MTRH and Rafiki Center, which is the adolescent clinic, to make sure that we keep improving and to help in those complicated cases. So Rachel, back to you. That's the summary for now, and I can extend it for another 30 minutes.
Thank you so much, Professor Nandiko. That's really, it's really stunning to think about all that has been built and your role in building that. Not only this care infrastructure that can provide care for 150,000 patients or more, but these innovative models of care that really are not just a model for this particular program, but across the world. And the research that's been generated out of this infrastructure to really answer questions, develop those innovations, test them, and so on. It's really remarkable. And for me too, the greatest privilege I've had as a pediatrician is this movement from taking care of so many very little kids who are sick up to now having clinics full of adolescents and young adults, and having some who are parts of our staff teams and who are themselves taking care of others. It's amazing.
Yeah.
Dr. Embleton, turning to you for a moment. So could you share with us a bit of background about your work with street-connected youth who are living with HIV, and perhaps for those who are not as familiar with what that might look like for their day-to-day circumstances, and what we're talking about when we talk about street-connected youth, if you could paint a picture around this population and what the work has looked like with them, that would be a terrific starting place.
Absolutely. And thank you as well for having me here today to speak. And before I dive in, though, I need to give you my heartfelt thanks for your dedication to the late Dr. Paula Breitstein, and acknowledge that my work with street-connected young people and the work I'll speak a bit more broadly to today was done under her leadership and remarkable vision to achieve 90-90-90 with and for this young key population. And her brilliance and passion and leadership are deeply missed, and I'm hopeful we can carry on her legacy and vision and research with this so often overlooked and neglected group of young people. But for those of you joining us today who are unfamiliar with street connected young people, this term refers to children and youth who find themselves spending a portion or majority of their time living in or working on the streets. So for these young people, the streets play a central role in their everyday lives and in shaping what they have highly stigmatized social identities. And so some of these young people may go to the streets during the day and engage in informal income generating activities to make some money, like collecting recyclables or garbage or carrying people's luggage. And then they return home at night and generally maintain ties to either parents or guardians. And others spend days and nights on the streets struggling to survive. They might sleep in the rough outside or in makeshift shelters, and this leaves them highly vulnerable to violence and abuse and exploitation. And for survival, many girls and young women connected to the streets engage in transactional sex. So overall, this group faces and experiences a multitude of factors that place them at much higher risk of acquiring HIV, as well as if HIV positive, these same issues really play into whether they initiate antiretroviral therapy, remain engaged in care, and achieve viral suppression. So our team's work really seeks to engage street-connected young people along the prevention and care continuum and address many of these structural and social factors that I mentioned, such as poverty, homelessness, gender-based violence, food insecurity, and stigma, just to name a few, that are really barriers to this population engaging in HIV services. And at the core of this work is a focus on addressing inequities. And I'll briefly give an example related to a combination HIV prevention strategy. So we adapted and pilot tested an evidence-based HIV prevention, gender, and livelihoods intervention, and actually combined it with innovative match savings program, whereby young people could save a small amount of money on a weekly basis. And then if they attended the interventions, educational sessions, then we matched their savings. So I think you can hear from what I've told you about street connected young people and from this example that for improving outcomes along the continuum for this young key population really requires multi-pronged approaches and really to address this array of structural and social factors that are influencing their engagement along the continuum. And that's really the primary focus of our work.
Thank you. That's a really helpful overview. You know, I was obviously I started with a brief story, but a story about faith, and it's one of the patients motivating my work in certain ways. And of course, we do honor and really hold up our colleagues' memories, Dr. Breitstein for all of us, and Dr. Massey here at Mount Sinai and in Elmhurst. But I was thinking, as we're commemorating World AIDS Day together, I do think it's important to honor the stories of those living with HIV, as it's so often those stories, the people, of course, that with whom we're interacting, who are motivating us in our research and the programs we're developing and in our advocacy. And I wondered if each of you might be able to share a brief story that comes to mind when whether it's when you're thinking about like a question you're trying to tackle or wrestle with, or something in the work that you're doing to continue to help us to understand when we talk about World AIDS Day, what World AIDS Day looks like on a daily basis for each of you and for each person living with and affected by HIV. Prof. Nyandiko, would you be willing to start?
Let me unmute. So Rich, I don't know where to start because there are numerous stories. But one that comes to mind is a young man who was then 8 years that came to the clinic around 2005. And 8-year-olds usually should be around 24 or thereabout kilos. This young man was 12 kilos, which is the weight of a 2-year-old child. and came in with severe pneumonia and very bad septic skin lesions. And that was the story of many of them. But I remember this particularly because that weight was just shocking. And then the living circumstances was that they were extremely poor, a family of 4. The father was alcoholic and couldn't take care of the family as well. We admitted this young man in the wards and treated him for the pneumonia and septic lesions. Of course, he needed a lot of nutritional treatment. And after 2 weeks, he was discharged back home, but discharged to an environment where there was no food. So I looked at this family. That time we were all struggling in terms of finances. A young doctor who is really also surviving from pocket to mouth and so on. But I was able to support this family for 6 months for their daily meal requirements for the 4 members of the family. And eventually also discussing with people who were able to give the mother casual job within the MTRH environment. And she took it up and was able to now support the family more strongly. We were able to bring the father on board in terms of trying to dissuade him from, being destructive, because the family was dysfunctional because of his alcoholism. But what is most striking is that with this small help that we gave to this young man and the family, the mother, of course, was also started on treatment. She was extremely unwell. We followed the young man, very regularly, and the initial treatment was extremely toxic, and they would come in and say, "I don't want to take this medicine." We had to do disclosure at some point, and that became a rough journey. But eventually, this young man joined college, went through high school, joined college. I remember actually when he was joining college, the mom came with a chicken. That is normal in Kenya. I mean, appreciation in the smallest way possible. And I said, "What? Why?" Yeah, said, "This one you must take." So I had to carry chicken from the clinic. You can imagine, I used to wear suits and ties that time, and walking along the corridors with a chicken to take to my car, because that was an appreciation from a very happy mother of a child who was now joining college. The young man finished college and is now actually employed. And he came to see me at the age of 22 years and much bigger now, talking with a very deep voice, all grown up. It actually made me shed a tear. We rarely do so. And but there are many, many other stories, many other stories. But beyond just the individual stories, the fact that we've been able in this landscape to go through providing Ministry of Health with the support in creating guidelines, in creating trainings, in mentorship, to expanding the number of facilities that can take care of children, to having technical working groups even within the regions now that are able to support those who are struggling with decision making, and ensuring that the clinicians who we are using to do the treatment have enough trainings to take care of the children. That for me is a big one, and not in a small way, because the HIV infrastructure we build, being able to use clinical officers, nurses, and training them has gone on to improve the care of the chronic diseases, the NCDs, using the same infrastructure, being able to diagnose people early, and so on. So it is a big area, when you now look at starting with treatment of those kind of very sick babies, coming all the way to building this research infrastructure that we're able to now review and say, these drugs are not good for this population of children, let's improve them this way, able to do clinical, randomized clinical trials and so on, is a real pleasure for me. So I leave that as my one example, but there are numerous others, including losing a young man who was now 18 years old because he developed cryptococcal meningitis. And the guidelines that time were not very clear on how you initiate ARTs vis-a-vis cryptococcal meningitis treatment. And we lost him. And it was a really sad thing, because he was very close to many of the peers that we now are using as youth and young adults to spearhead our program. And those are occasions that you kneel down and shed tears, and you almost feel like you didn't do enough. But we've done a lot to reduce the mortalities and morbidities in this group of children, and there are very, very many other examples. Back to you, Rachel.
Thank you so much, Ndiko. That is such a striking example of the resilience and strength of so many of our youth, and also the things that motivate us to keep trying to have better answers to these questions of how do we provide treatment, how can we do this better for more and more children, and addressing these really complicated medical issues and social issues over time as well. I love that you had a chicken to celebrate the Gallatin.
Yes.
Dr. Embleton, do you have a story that you might share with us along something?
Yeah, I mean, similarly to Prof, I think over the years working in Kenya and with young people, you end up with collections of stories. But thinking about resilience and young people, I have one story in particular that really has impacted me over time and my journey. So when I first went to Kenya, I did a lot of work at Tumaini Children's Drop-In Center, which was a drop-in center at the time. And got to know a lot of the adolescent girls and young women. We would spend a lot of time together, sitting, chatting. They would work on beadwork. We just really established these relationships. They lived very different lives than I was living. Many of them were still sleeping on the streets and experiencing extreme violence in their day-to-day lives, but we really bonded and formed relationships in my first kind of year living and working in Kenya. And for one of these young women in particular, we became very close. In my own journey, she came, she needed some work. And so she ended up coming to do some work with me in terms of, helping me around the house and things like that. But during, this time, she also had a baby as the result of sexual and gender-based violence on the street and really needed some additional support. And I was happy. And I think at the time people thought, you're inviting a street-connected young woman into your home. And because there is so much stigma. And I was like, yes, of course, let us build up her capacity and give her some financial resources to build her livelihood. But during that time, her and her child actually became ill. And, she had gone to the clinic several times, but didn't really, get an answer. And, at one point she was over at my house and I said, have they tested you for HIV? And I think you and your child should get tested. And I really encouraged her and supported her and said, we've got great treatments. And, if you do get on treatment, you will be able to live a long and healthy life. And she that day went to the hospital and tested. And yeah, her and her child were in fact HIV positive. And at this point was a very hard point in her life. And she required a lot of support and making really tough decisions for her and her child. And along the way, we maintained our friendship, and I tried to be supportive in any way I possibly could and keep her informally employed. And she went through this really challenging journey, but came out extremely resilient. She got on treatment. She became virally suppressed. Her child became virally suppressed. And she went on to actually be engaged, informally by many people who I was friends with. That kind of power of networking remained undetectable. She went on to have 2 more children who are HIV negative because, she was undetectable. She did, was engaged in antenatal care and delivered at MTRH. And I can say today, she actually has become a peer researcher and navigator as well, like one of these young people who really help show other people the way through the health system. And it's really that story and her story, which is so similar to so many other of the adolescent girls and young women connected to the street, living with HIV, that really continues to inspire me and propel my work forward. And I really have to acknowledge that, you know, the research I conduct and the researcher I am today, you know, would not be possible without these young people who have shared their stories with me, but who I've also had the opportunity to collaborate with.
Dr. Embleton, maybe digging a little deeper into what you were just saying in terms of how their stories and what you've heard from youth and your connections with them, how it's shaped, you know, what you understand and study and try out. Could you tell us a little bit about the kinds of ideas or, you know, things youth or witnessing their experiences have made clear in terms of how we can improve access to care or improve both either HIV treatment or prevention, especially for street-connected youth or really vulnerable youth with that? I know you've done a lot to try to get their ideas and really have them shape work that you're doing, and we'd love to hear about that a little more.
Yeah, I mean, absolutely. And I think, you know, to preface this, young people's participation and involvement in designing programs and making decisions about how they want to access and use healthcare is really fundamental to improving HIV prevention and treatment outcomes. And also, it's a lot of fun to work with young people. You know, often they have some of the most innovative and creative and contextually relevant ideas about how to improve services. And I have a few examples from the research we've actually done with young people and also just from speaking with them. But first is that, you know, they need multiple options for accessing HIV testing and counseling services. And they often put forth this idea of mobile testing. And I think this is a bit akin to the home-based testing and counseling, although many of these young people are not living in, you know, what we traditionally think of as homes, but they still want to be able to do this with privacy and confidentiality. And, you know, some of the suggestions they've had are bring a mobile van, you know, outfit a matatu, you know, make it cool, put, you know, slogans on the side and stuff, and bring it to where we are living and working to still provide privacy in a place where we are. The other is using, you know, providing peer outreach workers with HIV self-test kits. So they've put forth these two ideas where they can still test in private. And this because so many of them actually don't want to be seen going to the clinic still. You know, adolescents still experience a lot of stigma, and street-connected young people in particular experience intense stigma and discrimination in the health facility. Another is that, you know, young people we've talked to, they're brilliant, they're smart, they understand that the circumstances that they're living in actually leave them at risk for acquiring HIV. So, for example, street-connected young people have told us that their housing circumstances, so many times young people, you know, they don't want to sleep in the rough outside. So they in fact rent a room either in a low income or informal settlement with maybe 20 other street-connected young people and mixed genders, so both boys and girls, but in fact that leaves them very vulnerable to acquiring HIV. And they've told us they need a safe and secure space to sleep and be housed within to prevent acquiring HIV and not being exposed to violence and exploitation, but also to be able to be adherent to drugs and achieve viral suppression. And one last thing, you know, that they have told us is that they also need food. If you are on the streets, you know, you could be very food insecure, and to, you know, either take ART or PrEP, which is really important, particularly for adolescent girls and young women, they need to find ways to increase food security. And so actually a group of young people have actually said, you know, why don't you give out food with our ART? And, you know, actually, we pilot tested the approach of providing a hot meal with 4 street-connected young people who are taking their drugs in response to this need. And it has actually shown a lot of promise. So I think, well, some of these ideas might seem, you know, straightforward or simple when they actually come from street-connected young people. It really ensures that, you know, we are providing care and programs and services that are responsive to what they're telling us.
Thank you. Those are, and it's really helpful to think of those specific examples and what it does look like. And I of course agree with the fun aspect of it too, but the incredible importance of really listening to what the problems are and figuring out how to meet them, like literally where they are at, as well as with the needs that they bring up that way. Professor Nandiko, one of the things I was considering is, you know, we've heard a lot, and I know we have all three of us seen as well the ways in which we increasingly are concerned about the mental health issues for youth today, and I think that's really true around the world. In certain ways, the COVID-19 pandemic has made aspects of the mental health crisis perhaps more clear to some, though certainly we've seen struggles with this for quite some time. I wondered, could you describe for us some of the mental health challenges that adolescents living with HIV face, especially you know, as they move through adolescence, thinking about their HIV in a context with, in any context where there is still a lot of social stigma around HIV as well. And with that, you know, perhaps with an eye, as Dr. Embleton was sharing, for how we might find ways to support and strengthen their resilience in that as well. Oh, Nandiko, I'm afraid you're muted. If you could unmute yourself.
There you are. That's a big area, and I'll start by saying that the mental health crisis is really it's just starting. We are starting to know that there's been a big problem. In our own cohorts within Eldoret and in University of Nairobi, some of the studies which have been done showed as high as 50% depression in this population of children, and more so for those who are aged between 15 and 19, and has been associated again with those who are not adherent to treatment, so their viral loads are high, and those who are orphaned. So a combination of things that will make the treatment even worse. And the main genesis of this, of course, is the stigma that is associated with HIV. The fact that we are not able to appreciate the depth of this problem, and again, for many of us who have done work with the children as we treat them, we've been able to look at ways of improving even testing for stigma, because stigma-related or assessment tools are not things that were there before. So we've done work to validate some of those tools and be able to assess how much stigma is there. Fortunately for the younger children who are below 12 years, they are still not quite affected, but it becomes a big problem among the adolescents and youth because they go to school, they have to take medicines in front of others, and it creates a vicious cycle where they are unwell and then they are depressed because of many things. We have also looked at what happens during disclosure, and as you disclose the HIV status of a child who is now able to understand from 10 years onwards, we realize that many of them do actually get depression, but their caregivers get more depressed. So when you assess the caregiver versus the child, you find that the caregiver is the one who is even more affected. And of course, it is understandable because they fear what will happen once this disclosure is happening. So we have approached this in many ways, and one of the things that we do in the program now is to be able to assess their mental health status, using a standardized and validated tool within our program. And this again has become a big attention at the national level in terms of ensuring that as you give them care for their HIV, you actually are addressing the mental health requirements and needs. The biggest challenge we have in providing enough support for this group is really that we don't have as many specialists. And fortunately, we have a team in Eldoret which is working very well, has been able to train lower cadre persons to be able to assess for the mental status of these adolescents and children. And we are now increasing the number of psychologists who can support the children who are not well in terms of their mental status, because you cannot be well when your mental status is not okay. And it is worse if it's both the child and the mother who is going through this, this problem. Luckily, also within our programs, we've been able to get support from pharma companies in terms of treatment for some of the common mental health problems, including depression, anxiety, and that comes through as a very important support because ARVs are provided sort of free, although somebody is paying for it through that tax that they are paying. But now that support from pharma, where now if you get a child who has depression, who has a mental illness, you're able to actually have them put on treatment without necessarily going through going to pay for it. So it is a huge area, and I can tell you that one of the things that helps us is the fact that we're able to review our data and come out with solutions. For example, when you look at our population of adolescents, 50% are disclosed to at the age of 14. The biggest, the numbers are increasing now. We're probably at 50, 60%. And if you are not disclosed to, when you get disclosed to too late, then it becomes a big challenge to cope. So the earlier and the slow introduction, and we've had to now have dedicated structured way of doing disclosure that it goes through phases, and eventually somebody is fully disclosed, and therefore reduce the amount of depression or anxiety that is involved as we do the disclosure. So in brief, that is the area. But also the fact that we now have a research working group which deals with the mental issues, so mental health research working group, which has come on board with a lot of activities, both in the paradigm of care and research, but also in training. Our program within Moi University College of Health Sciences for training psychiatrists and psychologists is increasing. And that pool of personnel are important as we move to make sure that we take care of the adolescents and youth in this region. Thank you.
Thanks. Prof. Ndiko, maybe you could take one of the questions that has been put into the chat, which is asking about whether we've seen increases or decreases in how adolescents with HIV socially isolate themselves, perhaps as they're walking through the disclosure process or coping with issues related to living with HIV in stigmatized settings. I think you touched on this a little bit, but maybe you could talk about what that looks like currently still.
Well, I can. I mean, it's a very big story. I can give you a story. It's about 2 months ago. A young girl came to Module 4, and we had just disclosed to her, a partial disclosure, and she broke down and ran into the toilets there and locked herself inside, and it was, one of those very dramatic things. So those things happen. Once you disclose, you must be ready for the consequences. And so we try to make sure that the caregivers are able to give the support, because if you do it in the clinic and they go home, the person who is going to answer those questions is the caregiver at home. So we must have that support from the caregiver. We do a lot of use of our peer mentors, because they have walked the journey. That allows them to speak to the people who are being disclosed to in a language which is understandable. We do a lot of cohort management of disclosure, so that you are disclosing to a group of children who are almost the same age, and bringing them together in meetings beyond the individualized counseling and disclosure process, meetings which discuss broadly what is expected, and you bring in the peers to advise them and to give them the hope that this is what is this is the landscape as we go into, you get your full disclosure, and life will continue. So the support that we get from both the peers and a good structured system where you have groups coming together. We have celebrations among some of these when they get virally suppressed eventually, and so you have fun days where you do that. That improves a lot the mental health status and lessens the anxiety and depression that might come along with it. Then of course, the biggest challenge we have, and I'm talking because we are not only in the urban centers where you have the capacity to have people who can take time and counsel. Sometimes in the clinics in the peripheries, that opportunity is not there. People are so busy, churning the patients and forgetting that these small things should happen. The disclosure should be a process. The team should be happy welcoming these adolescents, because if you treat them the way you treat the adult, they don't want to come back to your clinic. But the majority will get this healthcare, unfortunately, because we don't have the luxury of space. We don't have the luxury of the specialists. Then we find that they fear coming to the hospital because that environment is not welcome. When you make it a good environment for them to join and meet people who are happy, who talk to them in groups, you'll find a clinician, a nurse, social worker, welcoming you by your name. In the busy clinics in the rural areas, sometimes your name does not exist. So very small things that we do and try to improve that even to those clinics that are a bit disadvantaged. But going forward, of course, some of those differences in the way you provide your services are important. For example, in MTRH, we now have the Rafiki Center for Adolescent Care, which has a broader mandate beyond just HIV. So you can get your reproductive health services there. You can get your mental health services there, diabetes. So people going there are not necessarily HIV infected, and that's a group of people who understand each other, and they go there and are able to interact, and it improves their general welfare. So many strategies, some of them that cannot be applied across because of financial limitations, because of infrastructure limitations, but we hope that incrementally, those are things we can have addressed.
Absolutely. And I wanted to say just there, while we still have everyone, the link that was put into the chat for the opportunity to give to the Kenya Partnership is actually specifically set aside funds to support what Professor Nandiko was describing, the peer mentor, peer counselor program for the adolescent health program in Western Kenya. These are, as he said, adolescents and young adults, in particular for the HIV program, many of who are themselves living with HIV, who serve as counselors, as advocates, as navigators in the clinical system, even to help make sure that youth who are coming in, know where to go, that they're followed up after, that they have someone they can ask questions to, that they can be as real as possible with in these ways. And we've seen them make an enormous difference through these processes. Some of these peer counselors also run the support groups for other youth as well. So if you're listening to this, it's really an incredibly cost-effective program, and that fund that link goes to has been set aside completely, entirely for funding for that program. So we would always appreciate gifts there. I'm afraid.
So Rachel, maybe I add one or two more things.
Sure.
One of the things that has happened is we also have noticed that the social media is a very good way of reaching the adolescents. So creating social media networks amongst them to communicate to us in terms of, they'll WhatsApp you or send you within a group that they trust you, and ask questions which helps them to go through questions they have about their mental health, about their treatment. We also do telecare for some of those who have more difficult, a more difficult disease or are not very suppressed, so that you keep communicating with them. So communication is so important, both at the level they come to the clinic and using the social media platform, which is a new, very effective way of enhancing communication and they'll ask very difficult questions which ordinarily they'll not be able to ask. And we're able to respond to them or even call them back and say, let's now have a chat on this question.
Absolutely. Absolutely. Well, I'm mindful that we've reached the end of our hour together. We still have plenty more we could talk about. I'm sure we could go for a few more hours if we had the time. But I think, these points of figuring out how to grow access, even, there's a question about PrEP, the preventive strategy of using medicines to prevent HIV, which is incredibly effective, but still is not widely available or not known to be accessible very often for young people. in Kenya and in lots of places around the world, where we both want to make it more accessible, and also even thinking about these kinds of strategies of social media, of very accessible connections of places and people through whom youth can readily access things like the preventive pills that you can take to avoid HIV infection, as well as, of course, contraception and other needs like mental health support and care, as we've talked about. Let me, on behalf of everyone who's joined us, as well as on behalf of the Department of Global Health and the broader School of Medicine at Mount Sinai, really thank both of you, Professor Nyandiko, Dr. Embleton, for joining us today. It is really a privilege to be able to talk with you today, but also, of course, to work with you and think with you together on this journey of how we might continue to improve health and access to health for kids around the world. So thank you so much for joining us, and we really hope that the rest of your World AIDS Day is full of hope, even as we think about and honor the memories of those we've lost as well. So thank you so much.
Thank you, our pleasure. Wishing all the HIV infected and affected families all the best, and hoping we shall actually cover the inequities that are there. We didn't quite discuss that, but there is a lot that needs to really improve. So thank you so much for inviting us to Rachel and the Mount Sinai team.
And let me just say something I forgot. The recording of this webinar session will be posted. Usually we have them posted within about 24 hours to the YouTube channel that we have for our global health webinars for Mount Sinai. So this is something that you can join and share as well. And we'd really encourage people to continue that. And we're always happy to talk more about these issues, including the details of the inequities involving children and youth and everyone living and affected by HIV as well. But again, thank you so much.
Thank you. Bye-bye.
Bye now.
Bye.